Hi, I'm John Ellis, and I'm pleased to talk with you today about postoperative myocardial ischemia and infarction. Please note that all the slides I will present are downloadable at this URL. I will leave it here for a few seconds, and I will also show it again at the end of the talk. Conflict of interest statement. I do work as a Speakers Bureau member as well as consultant to Baxter Pharmaceutical. We have to start by acknowledging that our outcomes in patients with known or suspected coronary disease have improved greatly over the last number of years. This is data from the University of California, San Francisco, and we see that 1-year mortality has decreased significantly and 30-day mortality has almost disappeared. So we're doing better. Still, we'd like to know which patients are at risk, even in the modern era, for perioperative myocardial infarction. A number of large database studies have been done to address this issue. One in the U.S. is the National Surgery Quality Improvement Program. This is a study that looked at over 200,000 patients. The rate of perioperative myocardial infarction or cardiac arrest was under 1%, and they found 5 predictors of these adverse cardiac events: the type of surgery, patients who did not function independently, abnormal renal function, advanced American Society of Anesthesiologists class, and lastly, increasing age of the patients. Now, traditionally, we have been told that patients who have suffered an MI are much more likely to have a second MI if they have surgery soon afterwards. And some have thought that in the modern era with coronary revascularization and also modern medical therapy that this may no longer be the case. But we see in this large data set from California in the early 2000s that patients who have surgery in the first 30 days after a previous myocardial infarction, almost 1/3 of them will go on to have a postoperative MI. So even in the modern era, having a history of myocardial infarction recently is a risk factor for reinfarction. This is a study from Spain. This is a registry wherein patients were given risk factors for the likelihood of adverse cardiac or cerebrovascular events. You see the more risk factors patients had, the more likely, up to 20% likelihood of having a major adverse coronary or cerebrovascular event. What they also showed is that the more risk factors had, the longer patients tended to stay in the hospital. And of course, none of this is surprising to any of us. Now, recently, there's been some work that suggests something that I've seen in my clinical experience, in that the patients who are at highest risk are not the patients with coronary disease, but the patients with congestive heart failure, and particularly patients with atrial fibrillation. And this retrospective study, again a database study from Canada, looked at the subset of patients who had heart failure and or coronary artery disease and or atrial fibrillation. And if we look at mortality in the blue here, we see mortality at 30 days, 9% for non-ischemic heart failure, 9% for ischemic heart failure, only 2% for coronary disease. And in fact, the associated mortality in patients who have atrial fibrillation is more than twice as great. So we are doing better in treating patients with coronary artery disease, but these other patients we need to be particularly careful about taking care of in the perioperative period. And in fact, an accompanying editorial says for these patients, even non-cardiac minor interventions could be associated with an elevated risk of early postoperative mortality, and that this is even greater than the risk of having a diagnosis of coronary artery disease. Now, we've seen some of the preoperative risk factors. We know these from other studies going back to Goldman and Lee and the revised cardiac risk index. What about the intraoperative period? Certainly we know that what goes on in the operating room is also important. From the University of Michigan, they mined their database and they found the typical preoperative predictors of risk: advanced age, heart failure, obesity, emergency surgery. Note here, if you've had a previous cardiac intervention, revascularization, you are more likely to have an event. cerebrovascular disease, and hypertension. But there were two factors in the operating room that also predicted risk. Long surgery, 4 hours or more roughly, and the need to transfuse 1 or more units of packed cells were associated with adverse outcome. In the study I showed you from Spain before that looked at the relationship between risk factors and length of stay and risk factors and major adverse cardiac events, they found the usual preoperative risk factors for adverse events, but they also found, again, very similarly, 2 risk factors that predicted bad outcome that occurred in the operating room. One was hypotension in the OR, and the other, again, just like in this study from Michigan, was the need to provide red blood cell transfusion in the operating room. Now, I'll just say a few things about anemia. One of the things we know is that the combination of anemia and heart disease or anemia and other chronic comorbidities is a risk factor for adverse outcomes in the perioperative period. This study in the Lancet, for example, shows that patients who have cardiac disease but are not anemic have a very low mortality. If they have either anemia or heart disease but not both, now we see an increase in mortality. If they have heart disease and anemia, there's a further large increase in mortality. So preoperative anemia plus medical comorbidities significantly increases mortality. Now, I'm not sure what we should do about this. We know that anemia is bad. We know that blood loss is bad. We also know that blood transfusion is bad and that old blood is particularly bad in terms of causing microcirculatory failure. And so I would say that I am still confused as to how we should manage hematocrit in these patients. One thing we do know from a large, again, retrospective study in Toronto in Canada is that the combination of anemia and beta blockade may be causing serious problems. In their study in Toronto, they found that major cardiac complications and mortality were increased in beta block patients who had more than a 35% drop in their hemoglobin concentration. And they suggest that beta block patients may not tolerate surgical anemia, and they don't have the ability to increase oxygen delivery. And while that might protect the heart, that may not be good for the kidneys, may not be good for the gut, may not be good for the brain. Well, what do we understand about the pathophysiology of perioperative myocardial ischemia? And this has been debated in recent years. There was a nice review article in Anesthesiology that suggested several mechanisms. Number one is supply-demand mismatch in the postoperative period, increased demand, hypertension, tachycardia, perhaps decreased supply from anemia, and you can have prolonged ischemia, subendocardial MI. But these mechanisms, plaque rupture, plaque hemorrhage, and thrombosis, may produce larger myocardial infarctions where one may see a Q wave and really large increases in troponin. And different researchers have asked which of these two mechanisms, prolonged ischemia due to supply-demand mismatch or primary problems in coronary perfusion, predominate in myocardial infarctions that occur after surgery. My reading of the literature suggests that probably 2/3 of perioperative MIs are due to relatively fixed lesions with increased demand, but that maybe 1/3 of perioperative MIs are as the result of plaque rupture, thrombosis, vasospasm, and perhaps thrombosis that can go on to produce an acute coronary syndrome. Well, the mechanisms that one can identify depends on the patient population studied. If one does autopsy studies, you're likely to find the patients who've had the largest transmural infarctions. Other studies looking at preoperative coronary angiography have found that only 2/3 of the infarcts are actually identified on preoperative coronary angiography, which suggests that the infarcts occurred from plaque rupture in areas that were not stenotic enough to show up there. And obviously one can do postoperative surveillance with troponin and or EKG and or symptoms to see which patients develop myocardial infarction. And these will be different populations, highest risk, higher risk and probably lowest risk group of patients here. Well, one recent study, and this is from Sao Paolo, looked at patients who survived a perioperative myocardial infarction, and they found that nearly half of these patients had evidence of coronary plaque rupture. These patients who had perioperative MI had more complex coronary lesions, and unfortunately they found when they compared to a group of normal, patients who had myocardial infarction and were cared for in a coronary care unit not after surgery, the surgical patients were less likely to have use of medical therapy, statins, beta blockers, aspirin, and the like. And this suggests that we might do better in our medical therapy of our patients undergoing surgery. On the other hand, here's another study that suggests that the majority of perioperative MIs are actually due to demand issues, that the number of thrombotic myocardial infarctions is relatively low. So depending on the data you choose to look at, and again this depends on the different patient populations, but somewhere between, I would say, 1/3 and a half of perioperative MIs are probably related to some amount of coronary plaque disruption. Now, these authors who said that the majority of ischemia and infarction was related to supply-demand mismatch said that therefore they recommend revascularization of stenotic lesions, the use of perioperative beta blockade, aggressive postoperative pain control, and avoidance. They don't recommend anemia, they recommend avoidance of anemia. Again, these are all controversial topics. We know that beta blockade is controversial. We know that early on there were a number of trials that showed protection, then a number of trials that had equivalent or questionable results. And one of the things we saw in the large POISE trial, which was published in the Lancet in 2008, this was a very large study, they found indeed that beta blockade reduced myocardial infarction, but at the risk of having more cerebral vascular accidents. Again, we're not only interested in the heart. The heart may do better with beta blockers, but if it puts the brain, the kidneys, the gut at risk, that's not good. It also needs to be pointed out that in the POISE trial they used very large doses of perioperative beta blockade. The European guidelines have been strongly in favor of perioperative beta blockade, but they were written with the lead author being Professor Don Poldermans, who has left his university post, and there's some controversy about whether or not the work that he and his group in Rotterdam have done will continue to inform the European guidelines. Again, to remind that we're doing much better. This, I showed you the slide earlier, significantly decreased mortality in our patients with known or suspected coronary artery disease. A lot of that has to do with beta blockade and their experience at the University of California, San Francisco, and we recently published a review in the British Journal of Anesthesia in December 2011 that's a really pretty up-to-date review of perioperative beta blockade and looks at the controversies in this area. The other thing we need to keep our eye on in terms of medical therapy are statins. There have been many studies that have shown benefit to their use in the perioperative period. One study from Paris showed that if patients undergoing major vascular surgery had discontinuation of their statin drugs, they were more likely to suffer perioperative myocardial infarction. And let me just say I have no conflict of interest with the makers of this product here. We have to also remember that surgery is a hypercoagulable state, that hypercoagulability is associated with thrombotic events. We know that platelets can stick to damaged endothelium. We see this on this electron scanning microgram. And this is really a problem in patients who have had coronary stents, and particularly drug-eluting stents. These patients are typically maintained on dual antiplatelet therapy for at least a year. And if this therapy is stopped, and that was the case in this case report here, we see acute coronary occlusion. Patients suffered a cardiac arrest immediately upon arrival to the recovery room after a major urologic procedure. We know that normal bare-metal stents quickly become covered by endothelium, but that the drug-eluting stents do not quickly become endothelialized. We see here with the Cipher and the Taxus stent, and therefore they serve as a place where blood clotting and thrombosis may occur. And there's been much controversy on this issue. In this journal last year, there was published a nice review, a consensus document on perioperative management of antiplatelet therapy in patients with coronary disease. They go through their recommendations in this chart here. I will not take the time to go through all of these, but again, I urge you, you'll see in the last slide, I'll have the URL, the website where you can download these slides, and this is actually a link that you can click on to see the data here. And so they have their recommendations for when one stops aspirin, for when one stops clopidogrel, etc., in patients who are at high risk. Now, this is a complex decision-making process, and there's an accompanying editorial that says that this is actually, these statements are based on consensus rather than evidence. We really haven't seen good randomized trials in this area. But what we do know is that patients who've had stent implantation, we see in this one database over a 4-year period, almost 1/3 of the patients had subsequent non-cardiac surgery. So this is a real issue in this patient population. I can tell you in this study that they did not find differences in cardiovascular events between patients who had antiplatelet therapy stopped or not, but others have certainly found that patients, particularly in the first year after stent implantation, that if their antiplatelet therapy is stopped, they are more likely to have coronary thrombosis, and that the associated mortality is very high. What they showed here also, and this has importance in terms of when we monitor patients, if you look at when the adverse cardiac events occurred, the vast majority occurred in the first 2 days after surgery. So there were some that occurred afterwards, but we see here the majority occurred in the first 2 days after non-cardiac surgery. Well, we have moved from relying on creatinine kinase myocardial band and ECG to troponin as a way of diagnosing ischemia and infarction and also giving prognosis. Again, I talked about 2 types of myocardial infarctions, transmural myocardial infarctions that might be associated with the Q wave, which really generate large peaks in troponin. And then this is more the type of troponin elevation that one might see in a patient who suffers prolonged supply-demand mismatch and eventually does have some myocardial necrosis. We know that there is a dose-response relationship between the amount of troponin released after vascular surgery and mortality at 6 months. And we see that if patients have more than 1.5 nanograms per mil of troponin I, we see that their mortality at 6 months is approximately 20%. So if you find patients who have postoperative troponins, I believe it's worth referring them to a cardiologist to try to provide medical therapy to reduce this risk of subsequent mortality. I just will show you some data from a recent study of carotid artery stenosis. This was a randomized trial of patients receiving either open carotid endarterectomy or coronary angioplasty and stenting. And what's interesting here is that you see that patients who have an MI are more likely to be dead after 4 years than those who do not have a perioperative MI after a carotid revascularization. But note this, the patients who, if anything, had the worst outcomes in green were patients who only had a biomarker. They did not even have symptoms associated with their increases in troponin or CKMB. So again, I think this is evidence that patients who have elevations of troponin after surgery are patients that should be referred to a cardiologist. We have published some work that suggests that, at least in patients undergoing abdominal aortic surgery, that this is a cost-effective practice. That is, by identifying patients who elaborate troponin, who are then at high risk. If one can aggressively intervene in these patients, they may do better. This is a synthetic decision analysis that was performed, and I must admit this was a larger operation than some others that might go on. But again, there may be some benefit to monitoring troponins routinely in high-risk patients. There are some newer high-sensitivity troponins, and these are just being investigated now. One of the possible benefits is that they would tell you earlier in the course of an infarct when a patient was having problems to give you a warning to start to intervene on their behalf. My troponin recommendations, these are my recommendations, is to routinely measure in patients with suspected coronary disease, high-risk patients who are undergoing intermediate to major surgery, who show themselves to be unstable and have intraoperative hypotension, have large blood loss, and perhaps require transfusion. And I believed, based on the data I showed you, that asymptomatic troponin elevations merit referral to a cardiologist for consultation. And I will tell you, even though cardiologists often may not do much with small troponin bumps that may occur after surgery in the absence of symptoms, at least one hopes that they can optimize medical therapy, and that may be statins, that may be aspirin, that may be beta blockers. And so I think this is an editorial from several years ago, but I think this summarizes nicely where we are today. We have moved away from so much of doing stress tests to predict which patients are at risk. We can do this with history. We can then integrate what happens in the operating room, as we mentioned, blood loss and hypotension and the like, and that can give us some idea of risk. But what's ideal to do in these patients is to move away from risk stratification to therapy. And we've talked about several of these therapies. I call this my breakfast of champions. I believe aspirin, despite the concerns about bleeding, is a useful drug to continue in patients who are on it for coronary disease. Beta blockers, obviously controversial. This is metoprolol here. The only conflict of interest I have with this is that I used to take this medication for hypertension, and the statin drugs. And I think when these drugs are administered in intelligent, judicious ways, they have the potential for reducing perioperative myocardial ischemia and infarction. And so, again, it has been a pleasure to discuss this issue with you. Please note you can download all of these slides here from this URL down here, goo.gl/ and this is case sensitive, FCQME. So please feel free to download the slides, and thank you very, very much for your attention.